to wind back now. So hello everybody, and thanks a lot for the invite. It's a great pleasure to me to speak at this huge conference in India. And Professor Thieme has mentioned already our conference in Germany. So and we'd be very happy to have some of you joining it there. I will talk about a more recent method, let's say, or concept, which is called mix. And I was asked to talk about the crucial question whether mix can stand the test of time. And I invite all of you to go through it with me together. So we all know, this is just an introduction, that IOP lowering is the only evidence-based treatment to halt glaucoma, because this big elephant is jumping on the lamina cribrosa. And we all know that the only evidence-based treatment is to get this pressure down, to get the elephant jumping not on the lamina cribrosa, but maybe somewhere else, or not jumping at all, let's say. And we all know that the big studies have shown that the pressure reduction reduces the pressure. But the crucial question is, how can we achieve it? And of course, we all know that most of us start with drops or maybe SLT, and we start with 1 drops like here in 2016, then we see progression, nasal cupping. So we introduce a 2nd drop and we see more progression, and we use a 3rd drop, but the patient still progresses. So I think that's the dilemma we always have in clinics everywhere in the world, in India, in Germany, wherever. And the question is, how can we solve that problem, especially if the patient says, I can't remember if I forgot to take my eye drops last night. So it's not only about the effectiveness of the drops, it's about the adherence of the patient, which might be weak. And sorry, and if we talk about this, I will just show you, this was the slide, that the trabeculectomy has stood the time, because it celebrated its 50th birthday some years ago, basically. And it's still available in the 21st century. There have been big multi-center trials and analyses testing the effect of it. And it's still, let's say, the gold standard for glaucoma surgery. It's been enhanced by the use of antimetabolites. It's reproducible and standardizable. It's cost effective. And like, for example, this study has showed that almost 80% achieved a target IOP below 18 and 20% reduction of the pre-op IOP without drops. So we know one thing for sure, I don't have to tell you, that trabeculectomy did stand the test of time. But what about the complications? There are some complications. There might be encapsulation of the black, which needs revision, bleb leaks, a shallow AC, choroidal detachment. Every glaucoma surgeon has gone through all those complications. And that's sometimes not easy to deal with the patients and to handle the patients and to revise those complications. Although they are not very, very common, they're still difficult to deal with and difficult for the patient. So the new era might be minimally invasive glaucoma surgery. What does it mean? It means that, that there's minimal tissue destruction, there's a short surgical time, simple instrumentation, and fast post-operative recovery. The definition changes a bit on whether you're in the States or whether you're somewhere else, whether it's like clear cornea cutting and not non-touching of the conjunctiva. And recently, this term has moved a bit to being differentiated between mix, which is minimally invasive glaucoma surgery, and on the other hand, there's LIGS, less invasive glaucoma surgery, which might include touching the conch, and I'll explain it now. Well, what methods with this minimally invasive surgery do we have? There are 3 different solutions at the moment. Increasing the trabecular outflow as a natural flow with the iStent, the iStent Inject, the iStent W. You can see already this device has changed over time slightly. The Hydrus, which has been newly launched now in Germany 2 months ago, the trabectome, and the Cahook dual blade. There might be increasing the outflows through the suprachoroidal space by means of CyPass, which has been taken off the markers, or the iStar, which is kind of similar, or creating a subconjunctival space of outflow. So the first one will be increasing the trabecular outflow, and I go through it with you. What do we have? Well, actually, there's loads on the market. First of all, there's the Hydrus micro stent, which you can see in the upper bit here, which is meant to be restorative, you could say. There's the iStent. Nowadays, it's the iStent W. There's the up internal canaloplasty by dilating the canal, and there are more disruptive procedures, you could argue, with the trabectome or the Cahook dual blade. So the iStent G, I'm just going to show you some pictures, is the smallest implant we have on the market. And it was launched as the iStent, which you can see on the upper right. And then it's been modified to the iStent Inject, because it seemed more likely that the pressure would be lowered better if there would be two sides where the stent could be placed. As the Schlemm's canal is not like a tube, it's got little folds and it's got little walls and everything in it. So it's more likely to reduce the pressure if you put more than one. So the iStent Inject, and nowadays the iStent W. The Hydrus microstent is the largest of all the implants, you could argue. It faces the Schlemm's canal by 90 degrees and dilates it and is meant to restore it. It's 8 millimeters in length, and it's quite of nickel. So here's a video of how you implant it. Actually, you see this injector, you find the trabecular meshwork, and then you just roll it forward, and you can see the Hydrus nicely placed in this Schlemm's canal. Sometimes you just have to adjust it slightly if it's not well positioned by pushing it a bit forward, but once you are in, and you can see all the 3 windows here shown nicely shining through the trabecular meshwork. This is a perfect position of the Hydrus. So the next one would be, apart from those, increasing the outflow through suprachoroidal space. We've heard before about the Cahook and the trabectome, which would be meant by the CyPass or the mini inject. So this is the mini inject and the CyPass. They both are meant to enter the suprachoroidal space and increase the outflow via the suprachoroidal space. This is a video of just show it for a proof of concept of the CyPass. I don't have any video of the mini inject. So you do the same. You've got this gonioscopic view. You do a small clear corneal cut. You enrich the anterior chamber with some helon. Then you plant the device. You look for that space. This is the implant. You have to look a bit to be in the correct position to enter the suprachoroidal space. That's for sure the most difficult bit of it. But once you are in and you can move it forward quite easily. You can say here, position found underneath the trabecular meshwork, which is here quite nicely visualized, and you just push it forward, and the same happens with the iStent Inject. That's the other concept. The third one is creating a subconjunctival space, nowadays named as LIX rather than MIX, maybe as less invasive, because you still touch a conch, you have better IOP lowering effect with more complications. And you can see here, the Xen stent and the pressure flow, which I haven't shown here, is a similar device, but you have to open the conch completely. Even the Xen has been launched as a 45 one, but now the 63 is available, having the advantage that the lumen, as you can see here, is 63 micrometer, is slightly bigger, so having a better flow. And the injector has changed a bit as well, so it can fill the whole incision site. So you don't get early onset hypotony, which happened before with the Xen, because the injection site is larger than the filling of the stent. This would actually close down after a couple of days, but not initially. So here's a video of the Xen stent implantation. You do a small paracentesis as well. I'm going to just move a bit forward. You inject a bit of helon. This is the injector. You go all the way to the other side. You can do it with gonioscopic view, or you can't. you make sure that the iris doesn't move. You saw like the iris moved a bit, so you were a bit too not into the correct position, and you just push it in. You see the small tip coming out, and then you push the Xen stent in underneath the conch, and you retract the injector. You just retract it. Ideally, you can only see it, you can hardly see it, and you've got Xen underneath the conch. You make sure that it's free and there's no pigtail later on. Just make sure it's freed up and you don't have any pigtails. You can see it's here slightly underneath the bleeding. That's the stent, and you just wash the healon out again. So actually, where are we? Like, what are our options? Actually, if you think about it, in glaucoma, we've got so many options, maybe as many options as no other eye specialty has already. So you start with medication and the SLT later, then you have got the trabecular meshwork stents, let's call it ICE and Hydrus, and then you have got the LICs, the Xen, or the PreserFlow stents. You've got deep sclerectomy, we've heard about it, and canaloplasty as non-penetrating glaucoma surgeries, very nice, and last but not least, the traps and the tube shunts. So, and the risk increases if you go here to the right side, and the IOP lowering increases as well. So the better the IOP lowering effect actually is, the higher is the risk. But the crucial question, will it stand the test of time? Well, what are the characteristics we need? Well, it should still be present. There should be an IOP lowering effect over time. There's a good risk profile, a good quality of life effect, and there's a cost effectiveness to last over the years, like the trabeculectomy did. So first question, is it still present? Well, actually it changed if we think about it. So the devices changed, like the eye stand has been changed twice already. The Xen is about to change completely. Let's see what the comparison studies say about the Xen 45 and the Xen 60C. And the CyPass has been taken off the market. So actually you can see that it's changed a bit, and they are making better and better probably. What about the IOP lowering effect over time? Well, what does mean over time? If you think about our patients, of course, it depends on how young and old the patient is. A 40-year-old, it should last for years. And the eye stent, what is known about the eye stent for sure? There's not too much, but there's a good Cochrane review, and it says that it's uncertain whether there was any difference in terms of mean reduction in IOP from baseline. The Horizon trial shows good results for the Hydrus. The 5 years results show a good IOP lowering effect from baselines, although combined with phaco. They combined phaco versus phaco alone, and combined with phaco, it had a lowering effect of -7 micrometer over time. But the difference of the Hydrus alone only made 2 millimeters of mercury. So you get an additional effect to the phaco with the Hydrus of 2 millimeters of mercury. But the Cochrane database review says that there is mild to moderate open angle glaucoma. There's moderate certainly evidence combined with cataract surgery that it increases and requires less lowering, IOP lowering medication. CyPass had an IOP reduction proven as well, but it was taken off the market, as we all say, because of the endothelial cell loss. And the 4-year results of the Xen implant show good IOP lowering effect, although probably not as good as the traps. So what do we know? Although MICs seem efficient in the reduction of IOP and glaucoma medication and show good safety profile, there's evidence is mainly derived from non-comparative study, and further good qualities RCTs are warranted. So we still don't know. What about the risk profile? Well, the CyPass was taken off the market because of the endothelial cell loss. There's been recommendations for the care providers to not use it anymore. Compared to that, the Hydrus, of course, the company made sure that there's no endothelial cell loss. Over 5 years, there is none. As you can see here, it didn't change much. And the complications with the trabecular stent, at least, They are foreseeable and they are quite mild to moderate, no severe complications. It looks a bit different, although having the better OLP lowering effect, that, for example, in XEN and even in PreserFlow, the complications increase. Actually, there have been suprachoroidal hemorrhages described and choroidal detachment and shallow ACs. Quality of life effect is the next one. What do we know? Not too much, but there was no significant difference between TRAPS and MIGS in the quality of life 6 months post-operatively, although IOP was significantly lower in TRAPS. But still more studies have to be seen. And I think that's quite crucial to find more studies. And the last one is the cost effectiveness. What do we know? Well, the systematic literature review of clinical and economic outcomes of microinvasive glaucoma surgery in primary open glaucoma shows there is limited available evidence on the cost effectiveness of MIGS. And therefore, it remains unclear whether the cost using MIGS is outweighed by cost savings through decreased medication and need for further interventions. So I think even this topic has to be looked into a bit deeper. So to know whether maybe it will stand the test of time. And on the other hand, we not only have the TRAPS we need to think about. We've got the selective laser trabeculoplasty versus MIGS as well. So the question is, it has SLT is a low complication procedure as well, an effective method. So the question is whether MIGS provide any further evidence that it's even better as a choice for mild and moderate forms of glaucoma and accepted topical treatment. So finally, yes, they are still present. There's a moderate and IOP lowering effect over time. At least we've got the data from the Hydrus of over 5 years. The risk profile, at least for the trabecular stents, are good. And there's a recommendation that it can be used together with a phaco emulsification in those patients. The quality of life effect, surprisingly, there's not much data and we don't know yet. And the cost effectiveness still needs to be seen as well. And I thank you for all the attention.